has
Thanks.
started.
Good afternoon, everyone. I'm Lisa Emerson. I'm a Senior Policy Advisor with the Division of Financial Regulation and DCBS. Thanks again for being here. This is the 5th Rules Advisory Committee meeting for the House Bill 2002 Gender-Affirming Treatment Rulemaking. I'm going to go ahead and start off the agenda, and then Brooke will join here in not too long. So let's go ahead and get started with, I want to say again, welcome, and just go over some housekeeping for virtual meetings, etiquette. If you could just keep your lines muted if you're not speaking. And also, if you do speak, you would please introduce yourself and your organization that you're with and your role with the RAC. We are going to begin with the discussion being between the division staff and RAC members. There will be an opportunity for public comment later in the meeting time. And so interested parties will need to hold their comments until then, unless you're representing a RAC member who is unable to attend today. Okay, so with that, we're going to forego introductions because we have been meeting together for some time now. But again, when you do, as a RAC member or division staff, if you do raise your hand and are called on to speak, please introduce yourself. Thank you. So we're going to start with a review of the written comments that we received from RAC members after the last RAC member meeting on April 25th. So we did send those documents out with the all the materials. But we want to offer the opportunity for RAC members that submitted written comment to summarize their comments for the group. So we're going to start with Antoinette with Cambia, if you are with us. I believe that you are on the meeting.
Yes, good afternoon.
Hi.
Well, the comments were submitted. Again, I'm just going to go through a very high level because I do see that there are other RAC members and interested parties that also submitted comments, and I'd like to use that additional time to work out some issues that have yet to be addressed. So our letter basically was along the lines of about 3 major issues, again, with the definition of accepted standards of care. The consensus at the last meeting, or majority, was that the statements of recommendation be, removed. So we are wanting to know where does procedures that are considered investigational or not widely agreed by medical professionals to be safe, fit within the rules. That still remains to be addressed, and hopefully we can have a conversation and discussion about that today. Also with network adequacy, a few sub areas within that broader issue. The DFR has asked us what unreasonable delay mean and the timeframes we'd like to recommend. So we did provide a recommendation of 60 days as unreasonable, a wait time as unreasonable. And then also, we just needed more provisions added in the rules about the member contacting the insurer before going out of network. That we see language was removed in the latest version, so we would also like to address that. And then cost sharing. So if the member does go out of network, are we still allowed to balance bill like we do today, even if the other cost sharing is at the in-network level? So we are waiting still for that clarification. And then the DFR asked us what you wanted to learn more about a special case agreements. So we did provide some information about that for the DFR. So that was the gist of our comments based on the last version of the draft rules. Thank you.
Thank you, Antoinette. And next we'll go to Providence Health Plan, and I believe Bo Wrights is with us and representing Providence today.
Hi, thank you, Lisa. I'll just go over some of our main points broadly. So the first point we brought up had to do with the requirements in which a reviewing physician would be reviewing adverse benefit determinations for the coverage of gender-affirming treatment services. Providence is in support of keeping that requirement more broad as opposed to aligning with a specific education medium as currently outlined in the rules. Especially with some of the various restrictions when it comes to accessing these courses. And we fear that sticking to one specific course may restrict the timeline in which health plans may be able to comply with these rules, and also House Bill 2002, and furthermore may delay the reimbursement for such claims. I also want to point out, this was also mentioned in Antoinette's previous statement as well. We are concerned with the out-of-network coverage requirements in House Bill 2002. Although we are in support of the prohibition of balance billing for gender-affirming treatment, we fear that that will take away specifically the power with reimbursement negotiations from the insurer, and specifically thinking with cost growth in mind, we would like the DFR to explore ways in which that the reimbursement rates for gender-affirming treatment maintain reasonableness. And that's it for me. Thank you.
Okay, thank you, Bo. All right, and just I want to acknowledge an interested party, Mr. Paul Tredal joined late, and I just wanted to acknowledge that we will give you an opportunity at the public comment period to review your written comment that was submitted after the last RAC. So we'll have to hold off on that for now, and we're going to go to the next agenda item. And I will turn it over to Brooke.
Hello all, Brooke Hall, a healthcare policy analyst with the division, and we are going to go over the revisions that were made to the draft rule. So Karen, can you go ahead and pull up the draft rule? Okay, and the revisions really start in section 7. So if you can scroll down, Karen. Okay, up a little bit. Start at the very end of the last page.
Thank you.
There we go.
Right here. Okay.
Yes, thank you. Okay, so section 7 was completely revamped. Really, it was to make it more clear that this is an and in A and an or in BA, big B, big A, and big B, and also to more closely match statute. So this language is taken directly from statute, except for the last line in big B around meeting all the requirements in the various OARs that are listed. And I'll give just a brief overview of those OARs. So the first one is OAR 836-5053-1030, and that is written information to enrollees. And this outlines the requirements for insurers to provide written information to policyholders and enrollees of health insurance policies. The second OAR is OAR 836-053-1035, and this is a summary of benefits and explanation of coverage. And this rule outlines the requirements for the summary of benefits and the explanation of coverage that must be provided by insurers in Oregon. And then the last one that was added is OAR 836-053-1408. And this is required disclosures, and it outlines the disclosures that are required to be provided by health insurers in the state. So I'm going to stop and open it up for any questions, comments, concerns, feedback about this section. Scott.
Hi, I'm Brooke. Can you hear me okay?
I can.
Okay, great. Sorry, having some internet issues today, so I'm on the phone instead of the computer. Hi, Scott White, Director of Regulatory Affairs for Moda Health. I'm just wanted to address something in this section, and it's not something that was redlined in the latest draft, but when we're talking about application of cost sharing, because I heard, I think Bo mentioned prohibition on balance billing, and I do not see that in the statute or in this bill. This is cost sharing as in deductibles, co-insurance, or co-pays. I just want it clear that members, if they go out of network, would be subject to balance billing, which kind of underlines a lot of issuer points that we've had about the need to contact us, help us try to find and arrange this care, because it's not just because if you go out of network, you are subject to that balance billing. And I just wanted to make sure that was clear because, and Bo, I apologize if I misunderstood something in what you were stating in your comment letter, but I just didn't see anything in statute or in rulemaking that would prohibit balance billing of these services for out of network.
Yeah, thank you for that comment, Scott. And I'm actually going to let Lisa address this because after the last RAC, I believe she looked into some of the questions around balance billing. So Lisa, do you have any comments or feedback?
Yeah, well, I could just kind of briefly say that we, and including our team that's been working internally on this, agree with what Scott's saying, that it's really an and or an or here, where if there's an unreasonable delay, then an individual or a member, an enrollee can seek, request to seek out of network care when there's an unreasonable delay, or even if they want to seek care with an out-of-network provider for gender-affirming treatment for specific reasons. But there is no prohibition on utilization review policies, which would include prior authorization to see that provider. And really what it states here is if there's an unreasonable delay, which leads the individual to see an out-of-network provider, it would just be at the in-network cost sharing, which are those costs like Scott mentioned, co-insurance, deductibles, co-pays, not to exceed in-network cost sharing. So that would not necessarily apply to a balance billing issue. The enrollee would still be potentially subject to balance billing by the provider. There is a case though where I know that Antoinette with Cambia submitted information about special case agreements, also called single case agreements, which that's another arrangement that can be negotiated between the carrier, the enrollee, and the provider. And in those cases, sometimes there may be an agreement to waive those balance billing costs for the enrollee. So that's how we understand it, but we're open to other comments and feedback about this.
Thank you, Lisa.
You're welcome.
And Lisa,
Antoinette,
this is
go ahead.
Antoinette. I'm trying to raise my hand and it's not letting me. I don't know why.
You're okay, go ahead.
I think this is why it's important as part of the insurer's process. However, we choose to do this because, I mean, mind you, we are supportive on making sure that the member gets the treatment that they are seeking. According to the rules and the laws, but that's why it's really important that we have the ability to communicate to the member, to contact us, to assist them if you're trying to seek, an in-network provider and you're not able to within, the timeframes that it looks like the DFR is now adopting, which is the CMS's timeframes for the FFE. Or for plans offered on the federal facilitated exchanges, that they contact us and we work with them to try and find an in-network provider. So, we saw that language was removed from the rules. If it is removed from the rules, I mean, we want, the DFR to confirm or allow us as part of our processes, to utilize that service for our members so that they do get the services that they need. Because how do we know that they are actually did make the effort and find the in-network, provider within that time frame? How do we know that they did that? So I think it's important for us to have that, option of having the member contact us to assist them in finding an in-network provider if they're unable to within that time frame.
Thank you for that information, Antoinette, and that perspective. I did review some plan documents, and there's a lot of very clear instructions in there to enrollees, to members about the steps that they need to take. And there's a lot in there about communication with the insurer. So I feel like that is pretty clear, and we didn't necessarily want these rules to get down into that level of detail. And so that's why back, and I think it's in 3 on subsection 3, it talks about that there's no prohibition for carriers to use the utilization review practices. So that's more towards standards of care, but also, utilization review within, Oregon law is a practice where there would need to be communication from the member, the enrollee, to the insurer about these issues.
Okay, so
I'll
I'm
kind of leave
sounding
it
that.
there.
Okay. Thank you.
Thank you, Lisa. Thank you, Antoinette. Any additional comments, questions, feedback about section 7? Marlene.
Hi, I just wanted to say that I agreed with Antoinette's question, and I appreciate the clarification that Lisa just provided. So thank you.
No problem. Thank you, Marlene. Anyone else? Okay. I'm going to move on to section 8, which was added, and I'm hoping that this will elicit the most conversation. I will start out by saying that this, the definition of unreasonable delay was added after requests from various RAC members. And this, as Antoinette stated previously, is modeled after the CMS requirements for plans on the federally facilitated exchange, which is 30 business days for specialty care, 15 business days for primary care, and 10 business days for behavioral health care. This starts in plan year 2025 for those plans on the federally facilitated exchange. And I will just note that these requirements are not being enforced for plans on the state-based exchanges or state-based exchanges that use the federal platform. So first, this is really just a starting place for conversation, and I'm hoping that the language here will start to elicit that conversation, because I do understand that we are currently very far away from these timeframes. So any feedback, questions, hopefully conversation about section 8 and what should be how we should define unreasonable delay. Scott, go ahead.
Hi, Scott White with Moda Health again. Yeah, thank you. I'm glad to hear that these are conversation starters, because I had immediate concerns after reading this. For one, the federal wait time standards contain a 90% standard. In other words, members have to be able to schedule these appointments within a time frame of at least 90% of the time. So with the way this is written now, we're already stricter than federal wait time standards, which again, during a PCP shortage, I could almost, and I don't really think this is much of an exaggeration, but I could almost contract with every PCP in the state in my network and not meet these. And so it's very concerning that we're basically going to go, it's like signing a contract when you're already in breach of it by saying that we're not going to meet reasonable delay here right off the bat to get these services. We know some of these services in particular are months, if not longer. And there's only so many providers that we're able to, that in our area to even contract with to do that. And so to bring these in for this rule, I understand we're just, again, having a jumping off point, but it seems like we're setting up for failure and issuer non-compliance despite our best efforts. And I guess you could argue that for the CMS federal rules too, which we've had that discussion with the MBPP this year about these wait time standards, that so much is out of an issuer control, even if we contracted with everyone in the state, difficulty meeting these timeframes. So I just wanted to throw that out there. I think that I appreciate the leeway in our handbooks to have members communicate with us to work out these network issues and not just go out of network. And I think a lot of it can be handled that way. But these numbers that are in Section 8 right now are an impossibility. I'd love to meet these. It's just that it's not feasible with the amount of providers that we're talking about that are providing these services. It's not feasible in general or primary care world in Oregon, and in many places throughout the country. So yeah, just wanted to throw that out there, and just happy to hear what the DFR thinks about that. Thank you.
Yeah, I appreciate that, Scott. And you are correct. The CMS standards do include a 90%. They have to meet those requirements 90% of the time. So that was left out of this section. And if we do go with language similar, we will add that back in. I'm curious, previously, I think I asked, I don't know, 2 RACs ago, for some suggestions on a definition of unreasonable delay. And Antoinette stepped up to the plate in one of her comment letters and provided a definition of 60 days. My concern with that is that gender affirming treatment does encompass a wide array of providers. It encompasses specialty providers, primary care providers, and behavioral health providers. And having a 60-day time frame for all of those different providers, while that may be closer to where we are, I don't know that it is so far away from the federal standard, and we do kind of want to delineate out these types of providers. So I'm curious from those on the call, if we did include a definition of unreasonable delay that included appointment wait time standards, what would give you less heartburn. And I also just want to point out, Lisa just IM'd me and pointed out that I want to make it clear that this definition of unreasonable delay is only in regards to gender affirming treatment. It doesn't apply to our overall network adequacy rules. And if we do open up the network adequacy rules, we'll look at that during that time. So I'm going to move on. I don't know. Oh, I think Antoinette was next.
Yeah, so I should say that I support Scott 100% with everything that he laid out, due to the scarcity of just or the provider scarcity at this time. So I mean, what we're really looking for is just a little bit of leeway or some flexibility because of sadly the nature of just finding even a PCP. So I think the 30 days for specialty care, and this is not urgent, okay, and then the 15 business days for primary care and 10 business days for behavioral, is just too stringent, that there's just no leeway or flexibility for the insurer. That means we will be non-compliant all the time. And again, it's just because of the environment we're in right now. Hopefully in sometime soon, this is not more of a problem. And we can meet some of these deadlines, but at this time, it's just, next to impossible. So just some flexibility and some leeway, for us would be great.
Thanks, Antoinette. And Lisa, go ahead.
Yeah, of course, I want to hear all the other feedback from commenters, but just another piece of clarification to what you were stating, Brooke, is that this doesn't necessarily mean there's a violation of network adequacy. It's really more of a trigger for the obligation to cover out-of-network services from an out-of-network provider. That's really what we're trying to get at here. So if we can keep talking about what would be a reasonable or an unreasonable delay that would trigger this requirement to cover the out-of-network provider at in-network cost sharing, that's really what we kind of going to keep talking about.
Thank you, Lisa. I appreciate that clarification.
Welcome.
And Marlene.
Hi. So I was wondering When we look at those time periods, it really raises for us the issue of what an appointment is. So, we could see the time periods perhaps being appropriate for like a specialist or primary care or behavioral health care. But if the course of treatment involves a surgical procedure, we are wondering if the regulation should look more at the existing wait times in the local community for those services. So for example, looking at the wait times for a transgender patient looking for breast augmentation being equal to the wait time for a breast augmentation for a cis female, or a wait time for an orchiectomy to be the same as for any other urology surgery for a cis male. We understand that there's a desire to like move up the time frames and make sure that there's not an unreasonable delay, but we also need to look at the reality of the post-COVID environment where there are a lot of backlogs for everybody to get surgical services. And so again, sharing the concerns of Antoinette and Scott, we just don't want to be in a place where we're having to cover services out of network because the normal community for these surgical services can't get it done that quickly. And we appreciate having this discussion with you. Thank you.
Thank you, Marlene. And just for my own knowledge, because I'm not aware of this, and I don't think I've ever seen it in DFR, some of the information that we have in DFR. How do you know what the wait times are for the local service areas? Is that something that insurers are collecting?
I may be in a different position as part of an integrated system, but for example, if we are like, sending surgeries to OHSU, we know via our scheduling with them generally how far out they are. I don't know if there is like a broader community resource that would say that. I'm not sure if other carriers that are not an integrated system would have a better line of sight into that. But we saw the 30 business days, and the chances of somebody getting a surgery in 30 business days isn't super reasonable. Or, I mean, we would love for it to be reasonable. We're just not sure that it's the reality right now.
Mm-hmm. Okay. Thank you for that, Marlene. Seth.
Sure, thanks. I think I wanted to ground folks in the reason for the writing of the law that was really to focus on the poorer health statuses due to the extensive waiting and the level of extensive treatments that might also happen due to waiting. Folks are looking at feelings of developing mental health conditions due to the long levels of wait times. Self-harm is taking place in our community, suicidality, and also that has also led to other health conditions. Folks have indicated that they've experienced physical symptoms of body-modifying behavior, such as having to bind their chests for long periods of time over a year. That has led to other bruising of their bodies. There's been eating problems or obesity developed that would then make them not eligible for gender-affirming procedures if they're not meeting a certain body mass index of a surgeon. So I just want to kind of ground us in that level of discussion around the leeway conversation for allowing for longer times. This really was about making sure that folks have the ability to go out of network, not that folks won't be penalized, or not about penalizing carriers, but that folks have the ability to see a different provider and not just have to pay out of pocket. The burden of the finances for this for trans folks has fallen on them to raise the funds because insurance wouldn't cover out of network costs. And so that was really the basis of the goal of this. So if we can find a middle ground, I think looking at the actual numbers here, there are studies that have shown that over between 3 months to 6 months is when those negative mental health impacts start to begin. For folks in the Netherlands study, the Swedish study, there's another study in the United States, but we've looked at 3 months plus having the beginning times of those negative mental health symptoms. And then there's another study that looks at over a year to a year and a half, the impacts of that as well. So I think this is a good starting point. There is mental health studies on this. There's not a lot, which is sad. We'd like more research on our communities to work with. But I think looking at My question would be for specialty care, does that mean surgical care? Just a definition question off the bat. And then, yeah, I think looking at 3 months being the period of the onset of those negative mental health symptoms, typically in the studies I'm reading.
Thank you, Seth. And I just want to point out there is wording that was missed here. It should be exceeds 30 days for non-urgent specialty care. So I just wanted to point that out. And Lisa, do you have anything to add about the question around whether or not specialty care includes surgical? I haven't.
When I reviewed the, you know, the NBPP and the final rule, if you will, those were the categories, and so the surgeons fall into the category of specialty care. But we could double check that to be certain. And if anyone else wants to weigh in on that, please do.
Thank you, Lisa. And Rick.
Thanks, Brooke. Rick Black with Pacific Source. Sorry for being late to the RAC today. I mean, I obviously always have to agree with Antoinette and my colleagues in the insurance world. I would probably take it a step further, though, and just note that I feel like the way that 2002 talks about us constructing networks of providers without unreasonable delay kind of mirrors what's already in place in 743B 505, just the general network adequacy statute. Mm-hmm. I don't know that the legislature necessarily intended for, well, people can certainly correct me, that the standards were going to be different for gender-affirming care as they would be for just general network adequacy standards. I know a bill was considered and didn't pass that would have looked at more wait times and other issues. I think at this point, like, unreasonable delay is probably whatever factor or not factor-based approach that carriers take in order to meet compliance with current standards until such time as the network adequacy rules can be, the federal rules can be integrated into state law. I mean, I think at that point, then, you know, these standards look different, but then everyone's standards look different. So, and yeah, so I just think that if we're meeting network adequacy standards in every other kind of specialty, or at least, you know, or attempting to, given the shortage of providers that we're all seeing, I don't know why this is special, just looking at the law. That's just my point, though, but happy to stop talking now.
Thanks, Rick. I appreciate that comment. And yes, you are correct. There was a bill that we introduced in 2023, which would have added quantitative standards to our network adequacy statute, including provider to enrollee ratios, appointment wait time standards, although I think we might have called them appointment availability, and time and distance standards. And that bill did not pass, and we are still determining what the next step is for network adequacy and our current network adequacy rules. And Amy?
Hi, everyone. Amy Penkin, Program Manager for the Transgender Health Program at OHSU. I use she, her pronouns. You know, I don't think this is easily answerable, but it is a nuanced piece to this that I think is worth naming, around the importance of creating opportunities for individuals to seek care out of network at no additional cost. When we talk about these wait times for care and giving these numbers of days, it can be misleading in the sense that if someone can get in the door within a certain period of time to establish care, it doesn't say anything about the wait times within that care system. So we might have long wait times for someone to, after referral, to be established for a consultation, but access to surgery can be an additional long period of wait. And I would like us to be thinking about how we define wait times and what that appointment is, because it isn't always just about getting to consult. It's actually, at least in the realm of surgical care, it is also about progressing to surgery. And for some folks, that can look like a very extended period of time. And then I would want to underscore what Seth brought forward around the research studies that are demonstrating the impact on these wait times to individuals' mental health. And it is uniquely an equity issue for trans communities who are carrying unreasonable loads around social determinants of health. Thank you.
Okay. Thank you for that, Amy. Any other questions, comments, feedback around section 8? Okay. And I just want to remind everybody, I would love to see in your comment letters after the RAC any kind of proposed definitions or different ways to define this, or even suggestions for wait times in those comment letters to kind of help us to better refine this section. So moving along, section I think it was previously 7, maybe 9, I can't tell from that, I think it was 9, was removed because most of that language was included in the section 7 above. And 9, the language around demonstrating due diligence and provider scarcity was removed because there was concern about how the division would assess that. And because there is a specific legal definition for due diligence. But I do just want to state that it is still the division's stance that we will not hold carriers accountable for things that are outside of their control. So any questions, comments about either the language that was removed? Okay. So I know that this is the end of the changes that were made in this new draft rule, but we do have some extra time, and I know there were some questions from the comment section that people are hoping to get answers to. So if anybody wants to talk about any other sections of the rule or has questions for Lisa and I, feel free to raise your hand now. Okay. Well, I'm going to pass it back over to Lisa for the next section of the agenda, which is, I think, around the statement of need and fiscal impact.
Thank you, Brooke. Yeah, this is something that we do with all of our rulemakings, that we will be preparing a what we call the SNPI. So statement of need and fiscal impact is stated. And so if we could just pull that up, please, Karen, and go to the, the main questions that we would love, welcome your feedback on the entire SNFI when it's fully drafted. But it's really important that we hear from RAC members and even interested parties about how the adoption of this rule might affect equity in the state. So how is it possibly going to impact one group of people differently than others? That's very important. And then, of course, any kind of fiscal impact, economic impact, specifically to small business, making sure that we're considering all of your feedback. And of course, again, the cost of compliance for small business. So we've shared this document, and if you could take the time to consider these questions and provide us feedback in written comment, that would be great. And I would say that at some point we will then fully form this document and of course be sharing it publicly as well. So that's pretty much what I had to say about it, unless does anyone have any questions? And also thank you, Aaron Waters shared a resource that Marlene thanked Aaron for about wait time. It's like a physician survey. So thanks for that resource. Pass it back to you, Brooke. for the next agenda item.
Okay, I believe we are on to the section of the agenda for public comment. So is there anyone who is not on the RAC, an interested party who is interested in making a public comment? Please either raise your hand now or let me know. And I see Paul, go ahead.
Great, can you hear me okay?
I can.
Great, very good. So thank you for the opportunity. I won't walk through everything in my letter, but I'm glad you have that up to look at it. There were, I think, I laid out some of the concerns specifically regarding WPATH 8, and just broadly speaking, the more I look at it, I would really encourage you not to define any particular standard of care, because I think that really goes beyond sort of the intent of the language. One example I discussed with TK a week or two ago. If you go ahead and enshrine a particular standard of care in the statute, or in the administrative rules, you're not just putting out a laundry list of services that need to be followed. You're also mandating the decision-making criteria that, say, the medical directors working for the carriers need to follow when making decisions. That's something that just evolves continuously over time as new research develops and new things come out. And it's like one hypothetical example. Currently, all of the drugs being used as puberty blockers and cross-sex hormones are being prescribed off-label. None of them have been approved by the FDA. Let's suppose that, say, a year or two from now, one of those drugs is actually finally approved by the FDA, which would be great. So we'd have, finally we'd have high-quality evidence to support safety and efficacy, but that approval would come with a label, and that approved by the FDA, and that label would have some guidance. Again, doesn't mean you couldn't go off label, but the fact of that new research, the fact of that FDA approval, the fact of that label would really influence a standard of care. And I think we would reasonably expect both a physician as well as a carrier medical director to be paying close attention to that label and making decisions. But your rule, WPATH 8, would disregard that. And you'd be in a position where you'd have a carrier say, well, gosh, the standard of care based on this new label is X, but the Division of Financial Regulation has told me the standard of care is Y. And they would be kind of stuck. And you could, of course, reopen the rulemaking process, but you don't really have the expertise in the Division of Financial Regulation to make medical decisions like that and to evaluate whether the FDA decisions were good. So I would really basically discourage you from defining standard of care at all in the rules. There's a common statutory definition there. The second I brought up here is really relating to detransitioners, and this is essentially an issue because during the legislative process, Director Stolfi sent a letter to the legislature expressing his opinion that there you have it there, right? Expressing his opinion that HB 2002 is already covering it, and because you have put that in the legislative record, the legislature acted on that decision, that feedback. You really need to address it in the rules of the process. I mean, if at a minimum, if this rules advisory committee, and in particular the carriers, all get together and say, look, this is so obvious, we don't have to put it in the rules, and you sort of document that, then okay. But right now, I think it's sort of left hanging. You've got this letter on the record saying it's covered. It's currently silent in the rules. There's been no discussion in the rules advisory committee. It's really putting things in limbo, because you could have a patient coming in and saying, hey, this is covered. I am hearing from some detransitioners that they have been refused coverage, saying, hey, this is not covered. It puts the carriers at risk because they don't know what the standard is. And it's basically a recipe for litigation. And I think this Rules Advisory Committee should really address that. So I think you should put a brief provision in the rules stating that detransition is covered as you have described here. And then going forward in an updated bulletin, you should provide more context for how to apply that. but at a minimum, you should have something in the rules doing that. And if for some reason you've changed your mind and say, gosh, Director Stolfi made a mistake and shouldn't have sent that letter, then you really need to be public about that also and refer that back to the legislature, hopefully by like the September legislative days, so they can think if they need to do anything further. The last thing I wanted to bring up, not in the letter, but because you covered some of the impact statements, I think several things on the impact statements. One, in terms of small business impact, there are small businesses that are providing therapy services for individuals with gender dysphoria and gender identity related concerns. And I think you really need to talk to them and work with them to see how they would be impacted by a rule clearly specifying WPATH 8, because there are other sort of practices or other evidence-based philosophies and approaches that are maybe not fully consistent with WPATH 8. And by putting the rule the way you've done it, you may be shutting some of these small businesses out. And you should really be consulting with them or working with them to see what those impacts would be. We did at one point have a small business that representative that applied to join the RAC, but they were turned down because it was full. The second category that you really need to be addressing, and we just talked about detransitioners, you should really be working with detransitioners on the Rules Advisory Committee process and getting their input into this process. There was a requirement in here about including all impacted stakeholders. We don't know how many detransitioners there are. There are at least some. That's why Director Stolfi did that statement. And it is really important to talk to them directly to get their feedback in the process. And I think that the final thing in terms of the fiscal impact is the question of whether House Bill 2002 is a new mandate or not, requiring coverage that isn't already there. When I look at the bill and a fine reading, I don't think it is a new mandate the way it's written, but I am concerned that, and I think I've heard some of this from some of the carrier feedback, to the extent if you go forward with a broad reading that incorporates WPATH 8, that would start mandating coverage of services that have, say, would be experimental or investigational, that could be expensive, that would become a new mandate. And that would trigger some of the rules under the ACA requiring the state of Oregon to compensate insurers and or consumers for the cost of that additional coverage. So those are the key points I wanted to bring up.
Thank you, Paul. Any other public comment? Rick.
Sorry, I forgot to ask a question on the fiscal impact statement, so my apologies. There's a provision in the rule, I think I brought this up before, so this shouldn't be, I'm not trying to surprise anyone, but there is a provision that requires reviewing providers to complete the WPATH Foundations training program. Is that cost and who might have to take that course? Is that going to be integrated into the fiscal impact statement? I don't think the underlying bill necessarily goes to that level. So I just think it needs to be incorporated into the fiscal, however that you decide to do that.
Yeah, thank you for that comment. And yes, we would be incorporating anything that would cause a fiscal or economic impact, either to small businesses or independently owned, for small businesses. So we will be including that in the fiscal and economic impact statement. Any other comments? Okay. So now we're on to next steps. So first, I just want to thank everyone for the conversation today, especially as it relates to the definition of unreasonable delay. I think it gives Lisa and I something to think about in regards to making revisions to that. We will be making revisions to the rule based on the conversation in this RAC and based on public comment, comment letters that we receive. For comment letters, I'm hoping that you can have any comment letters to us by the 25th of June, which is 2 weeks from today. So comment letters the 25th of June. I believe if we do make, since we likely are making revisions to the rule, we may need an additional RAC meeting to discuss those changes, which will occur sometime in July, and we will get that meeting out to you as soon as we are sure that we are going to need another RAC meeting. So any questions about next steps, or Lisa, do you have anything to add?
I just would add that we have tentatively scheduled some time for later part of July, you know, the week of the, I believe it's the week of the 15th. So it won't be near the 4th or anytime soon. So yeah.
Thank you, Lisa.
Correct.
Both.
Hi, sorry, I'm having Wi-Fi issues, so I may have missed it. Is there a timeline for further feedback submission?
Yes, June 25th. That is 2 weeks from today.
Okay, thank you.
Antoinette.
Hello again. So with the possibility of having another RAC meeting in July, if that does happen, what is the timeline for adoption? And is adoption going to be, is it going to be effective on the date that it's adopted, or are you hopefully going to do a future effective date, like 1/1/2025, for example, depending on when it's adopted? Because I mean, we would need some time to, of course, update our policies, training, the whole thing to be prepared for this.
Yeah, thank you for that question, Antoinette. I believe the effective date in the statute is January 1st, 2025, and that's the date that we're aiming for an effective date. So we would need to have the to finalize the RAC at the latest, I believe, would be October, and then have a hearing in November to make that January 1st, 2025 effective date. And Karen, go ahead and correct me if I was wrong about any of that time frame.
Nope, you got it. So because of, well, this is kind of too far in the weeds, but yeah, then it would be a November hearing, definitely before Thanksgiving. So probably like November 15 type of a date for a hearing date. And that would keep us on track with the January 1st effective date.
Yeah, and Lisa just clarified for me that that is not the effective date in the statute per se. It's already effective, but we do want a January 1st, 2025 effective date for the rules.
Right.
So
okay.
Thank you for that clarification, Lisa.
Okay, that's what I thought. But I guess my concern more is that at what point do insurers and those that have to comply with the rules know that it's final enough to start the process internally of implementing it within the company? And a November adoption date kind of gives us a month to know for certain that nothing within the rules are going to change. So that's just my only concern.
Yeah, and I will just to let you know that Lisa and I are very much hoping that the July RAC meeting will be our last RAC meeting, and then we can move on to a rules hearing from then. But it's really going to depend on, you know, how much conversation occurs in that RAC, and whether we need to make additional revisions to the rule.
Okay. Thank you.
Any other questions, comments, concerns? Rick.
Just thank you for leading a tough rulemaking. It's not easy, if I remember right. So
I appreciate that, Rick.
Thank you.
All right, and with that, I'm going to give you all about half an hour back. I really appreciate your time today, and I look forward to your comment letters.
Thanks, everybody.
Thank you.
Thank you.
Thank you.